Well, we're going to talk about the next chapter, which includes the urinary system function assessment and therapeutic measures. The learning outcomes for this chapter is to identify the normal anatomy and physiology of the urinary system, discuss how aging affects the urinary system. You know how I usually include a question on that. List the data to collect when caring for a patient with a disorder of the urinary system, and plan pre and post procedure care for clients undergoing tests of the urinary system. We're going to talk about how do we care for people with incontinence issues and decrease the incidence of infection with those that have catheters. So just a review of the anatomy. We have two kidneys, and they sit retroperitoneal at about the costovertebral angle. The functions of the kidney are listed in your chapter on page 811, including the regulation of blood pressure, regulation of electrolyte balance, regulation of acid-base balance, regulation of all of that in both the blood and in tissue, the production of erythropoietin involved in red blood cell formation in the bone marrow, activation of vitamin D, which is necessary for absorption of calcium. There's a ureter or tube connecting each kidney to the bladder, which is a temporary storage area, and the urethra, which is where the outflow of urine to the outside of the body occurs. If you notice in the center, on the right-hand side of the kidney picture here, we have what's called the hilum, which is that indentation where the renal artery and vein enter and exit, as well as the ureter from the kidney, the hilum. You have both all three processes of urine formation. Filtration occurs here in the glomerulus, surrounded by the glomerular capsule. And then the very first part of the tubule that you come against, the filtrate will come against, will be the proximal convoluted tubule, leads to the descending loop of Henle, ascending loop of Henle, the distal convoluted tubule, and then the collecting ducts. And it's along the tubule as a result of the proximity of the peritubular capillaries, where we have both fluid, filtrate, and substances going from the tube to the blood supply, and vice versa from the blood supply to the tubule. The three processes in urine formation is filtration, reabsorption, and secretion. As we just mentioned, the locale would be at the glomerular capsule. The reabsorption occurs from the tube to the bloodstream, and secretion from the bloodstream back to the tube. The kidney is also involved in the excretion and conservation of water, electrolyte balance, acid-base balance, activation of vitamin D, production of erythropoietin for red blood cells, and production of renin, if you go back to your lecture in anatomy, where renin is released from the kidney and will contribute to the rise in blood pressure. The RAA will kick in, and the last step would be aldosterone, which was going to be to hold on to salt and hold on to water to increase blood pressure. The kidneys will filter 180 liters per day. So blood in our body is about 4 to 6 liters, so many times the amount of blood in our bloodstream is being filtered. The average is about 100 to 125 milliliters per minute, and we'll see the values when there's a kidney injury or chronic kidney disease. It can really go down quite low. The glomerular filtration rate is how much the kidneys filter in 1 minute. What's the formation of filtrate that the kidneys form in 1 minute. So and this picture shows the glomerular filtration, and I kind of talked about it already, where blood flows into the glomerulus through the afferent arteriole. The efferent arteriole is how it leaves, and only substances that are small enough to fit through the pores will get through. So blood cells, proteins will not get through as filtrate. Only those solutes listed here, like electrolytes, glucose, amino acids, vitamins, and nitrogenous weights, will filter out of the blood into the filtrate and go to the first part of the tube. The filtrate that goes into the tube will then go through the rest of it, the proximal, descending, ascending, and then distal convoluted tubule and out. And all along the way, it's going back and forth between the blood vessel and the tube to get the perfect mix of urine on the other end. So the rest of the anatomy of the urinary system includes the ureters, which carry urine from the kidneys to the bladder, which is the storage place for urine, and where the bladder muscles will release urine into the urethra, which carries urine out. Normally, urine is about 1,000 to 2,000 milliliters produced in a 24-hour period, and the color ranges from straw colored to amber colored, and the clarity, how clear it is, it should be clear. And the specific gravity ranges from 1.002 to 1.028. It tells us how well the kidneys are concentrating urine. So the lower the number, the more dilute the urine is. The higher the number, the more concentrated the urine is. Normal pH is 4.6 to 8.0, and if you remember, pH of blood is 7.35 to 7.45. So most times our urine is leans more on the acidic side. 6 is about average. So a couple things to remember under here is a protein that's high, a diet that's high in protein tends to be more acidic, and a vegetarian diet without protein tends to be more alkaline. What is water made up of? Most urine is made up of water, and that's about 95%, and the remaining is the waste products, including urea from the breakdown of proteins, creatinine from the metabolism of creatine in muscles. Uric acid results from the metabolism of nucleic acids, proteins. Aging in the urinary system. If we look at this slide, we'll see that both the structures and functions are affected. So the urinary bladder, there's decreased bladder size as well as tone of the detrusor muscle. The dysuria, urinary frequency, incontinence, and urinary retention are complications that may occur in aging. Regarding the kidneys, there's decreased ability to concentrate urine. So the pure number of nephrons decrease, and the glomerular filtration rate decreases. There's an increased risk from drugs or agents that are nephrotoxic. Think contrast dyes and some medications. Increased sensitivity as we age, resulting from GFR decrease. Females, pelvic floor muscles weaken. Females are more prone to bladder infections due to the length of the urethra, urinary incontinence, and urethral irritation. Males, as they age, the prostate enlarges, contributing to difficulty voiding and urinary retention. Some other aging and related changes include renal size is smaller and the blood flow can decrease by 50%, decrease tubular function, the bladder muscle weakens and capacity decreases, voiding reflex is delayed, and increased urination at night. About new onset of edema, shortness of breath or weight gain, fluid intake, and functional ability. Are they able to use the bathroom? How do they care for themselves? How can they get to the bathroom? Do they need assistance, etc.? So, have they noticed any changes in their urine color, amount, odor? And on page 817 are some new, in the middle, new onset of symptoms. Those would be things that we can ask. And dietary and fluid intake. Dietary intake, because of what we mentioned with vegetarian versus a higher protein intake and the effect on pH. Vital signs would be addressed. Blood pressure can increase with somebody that has kidney disease. Kidney disease can cause blood pressure, as well as blood pressure can contribute to renal disease. We're going to listen to lung sounds to see if there's fluid retention. Daily weights to assess for fluid balance, assessment of edema. I&O, somebody with renal disease may be on a fluid restriction, and we want to be pretty diligent on taking that. Some assessments of the skin include assessing for uremic frost. It really does look like there's a gray covering to the body, a gray cast to the body. And we're looking also for signs of a strep infection like impetigo, because impetigo, strep infections can contribute to glomerulonephritis. So whether it be a strep throat or impetigo is something we want to be observant for. If we look at respiratory rate, one thing we're considering with diabetic ketoacidosis or metabolic acidosis would be Kussmaul's breathing to assess for the body's attempt to lower the amount of carbon dioxide. And signs of fluid overload would potentially increase rate, as well as abnormal lung sounds, wetter lung sounds. So some lab tests that are done with urinary system disorders include a urinalysis, a very common test. You can take a voided or a specimen or a sterile catheter specimen, a straight cath specimen. A minimum of 10 milliliters of urine is needed. The first morning sample is a good sample to take. If it's not going to be tested within the first hour, it needs to be refrigerated. For a urine culture, we want to make sure that that the specimen is not contaminated, so proper collection is necessary. And we want to identify organisms that may be present, usually bacteria. So it's going to do a culture, and then a sensitivity added on that will be helpful in determining what antibiotic will treat that bacteria. So when collecting a specimen for urine CNS, we want to make sure that we give the antibiotic first. I'm going to give the antibiotic after we collect the specimen. The specimen needs to be collected first. A composite collection, an example of that would be a 24-hour collection, and some procedures on collecting a specimen such as that would be, if we're starting the test tonight at 10 p.m., the person's instructed to, at 10 o'clock, they will void, and that urine is thrown away. And then the collection starts. Every urine after that needs to be saved. The specimen is kept on ice or refrigerated, And at the end of the test, so 10 o'clock the next day, the test is over, you need to void, and that amount is then saved. That's 24-hour specimen. The 24-hour specimen can be used to look for at glucose, electrolytes, protein, catecholamines, creatinine, urine, urea, nitrogen, and minerals. So 24-hour specimen can be used for a creatinine clearance test that we'll see in a little bit. Back to the urinalysis, on page 821 are the features of a urinalysis, what's normal and what's abnormal. So if we can look at that on 821, if somebody's urine is malodorous, it could be a foul smelling, and that could tell you that it's possibly an infection. Be careful that you're not saying that there's a malodorous urine when the urine's been sitting for a while, because then it gets an ammonia type smell to it. In diabetes, you might have a fruity or sugary smell. In ketoacidosis, pH we already talked about. Specific gravity we talked about. I want to bring your attention down to ketones. Normally there's no ketones in the body, but ketones, when there are ketones, oh my goodness, normally there's not ketones in the urine. When there are ketones in the urine, it's telling you that the body has been using fats for energy. It's possibly somebody didn't have enough insulin, and insulin's needed to get glucose out of the blood and into the cells. So if glucose isn't in the cells, the body's looking for some other way for energy. So with the breakdown of fats, you get ketones, and ketones are seen in the urine. So in addition to somebody that has diabetes, you may also see people that are on ketogenic diets, low carb diets, will produce, you'll see ketones in their urine. In addition to somebody that's dehydrated, vomiting, or severe diarrhea, you'll see increased ketones in urine. The other thing I want to show you is nitrites. Nitrites will indicate an infection. Normally that is negative, but what happens with bacteria, they will convert the nitrate to nitrites, and that's why it's positive. Leukoesterase is an enzyme from white blood cells that's in the urine, indicating an infection. And cast, if you go to the very bottom of 821, cast, usually there's none. Occasionally you'll see a hyaline cast, but casts are formed when there's abnormal contents in the urine, will mold in the tubules. They could be from bacteria or white blood cells, red blood cells, or protein. It could mean that there's renal damage or an infection. So that's one other part of the urinalysis. Let's see. Talk about contrast-induced nephropathy. And contrast-induced nephropathy is a result of damage to the kidney as a result of using contrast for imaging. It can tell you by checking serum creatinine, you'll see that it's going up after a use of contrast, and you're seeing a decrease in how the kidneys function when the serum creatinine goes up, and it can result in death in a short period of time. Some risk factors: somebody that's an increased risk when there's increased waste products in the blood, diabetes mellitus kidney damage that's related to diabetes. And we should assess for allergies allergies to contrast when the person is getting an image done. Diabetes, the use of metformin, if you remember, metformin should be held 48 hours, 2 days prior to and after contrast is used. Somebody with a history of kidney disease, antibiotics use, antifungals, immunosuppressants, and anti-inflammatories, risk assessment should be done. Some imaging studies. A KUB. A KUB is an X-ray of the kidneys, ureter, and bladder, and will show kidney stones, tumors, enlarged kidney, possibly hydronephrosis. A pyelogram is an invasive study that shows an image of the renal pelvis and ureters, shape of the kidney, size. You can see hydronephrosis, polycystic kidney disease, tumors. And there's different types, IV, retrograde, and antegrade, listed here on this slide. Prior to the study, assess for allergies to contrast and obtain a creatinine level, creatinine clearance. After the procedure, to assess hydration status, pushing fluids. This is a picture of the IV pyelogram. Renal angiography, dye is injected and you can see the renal arteries, blood flow through the renal arteries. So checking for allergies to the dye, checking creatinine level. Post-study, the person may be on bed rest up to 12 hours. And just like our angiography that we talked about, coronary angiography during the cardiac lecture, you assess pulses, don't bed the leg or raise the head of the bed, watch dressings, vital signs, and peripheral pulses. Cystoscopy and pyelogram are studies where cystoscopy, where the cystoscope is inserted through the urethra. You can collect samples, biopsies, bladder stones, even stones up into the ureter, can be used to dilate the ureters, or can also be used to treat a enlarged prostate. A retrograde pyelogram, contrast media is injected into the pelvis and x-rays are taken. Another study that's often done is a renal ultrasound. It's non-invasive and you can see the anatomy of the urinary tract, shows stones and chronic infection results in tumor. Renal biopsy can be done through a needle biopsy or a small incision in the flank. Pre-care, the person will be on NPO for 6 to 8 hours and will receive a mild sedative. During the procedure, the person's going to be in a prone position. They're going to be lying face down. While the needle's being inserted in, the person will be asked to hold their breath. After the procedure, a bandage is applied, vital signs and output are monitored bleeding in the urine as well as at the biopsy site. And if you have increased bleeding, a decrease in your blood pressure, a rising pulse, that's a sign of hemorrhage, as we know. No heavy lifting will be done for at least 2 weeks. So nursing diagnoses for the diagnostic tests include anxiety, acute pain, altered urinary elimination, and deficient knowledge. And as far as anxiety goes, we know that we should be assessing for anxiety and provide help assistance in identifying coping strategies, keep an open line of communication, support both the patient and their family throughout any testing, encourage use of relaxation techniques, and address the client's concerns, and including providing information. With pain, we're assessing pain as we would where, how bad, what have you had it before, all that, and location. Is there pain on urination? Is there burning on urination? Is it abdominal or flank pain included? And provide comfort measures. It might be analgesics or a antispasmodic. It might be pain, warmth. It might be distraction. Report severe pain. Might indicate complications potentially of a procedure and may need more pain control intervention. Altered urinary elimination, so includes keeping an eye on the proper formation of urine of 30 mLs an hour. Decrease we're concerned. So hydration status, keeping an IV before and after the kidneys helps, before and after any testing helps protect our kidneys. And if they're getting contrast, helps flush the contrast from the body. Monitor INO, monitor that serum creatinine level, and observe for any hypersensitivity reactions to the contrast. The deficient knowledge, as we know, always starts with knowing where the client is, how much they understand. That's a jumping off point for teaching. We want to make sure that we are communicating with the patient, who are the people that will be caring for them, especially when they're going into a procedure room or operating room for any test. Orient the person to the environment, the equipment, and routines. Explain everything that's going on. Provide information at their level, and reinforce the explanations that were given and correct any misunderstandings. And patient teaching about self-care after the procedure, we can assist in as nurses. So let's talk about urinary incontinence, which is the leakage of urine involuntarily. And we're going to talk about the different types. So involuntary urine loss is less than 50 mLs that occur from increased abdominal pressure. You see it more in women than in men. May occur after coughing, sneezing, or laughing, that increased pressure in the abdomen, and it's a small loss. Urge incontinence is an involuntary loss that occurs with a strong a sudden desire to void, and Kegel exercises will help a client that has urge incontinence. This is somebody that just is not getting to the bathroom fast enough. The urge comes on so suddenly. Functional incontinence, we need to consider those that are dependent on others for mobility as having functional incontinence. Perhaps want to make sure that assistance is provided. So a bladder schedule of voiding every 2 hours might be something that we are involved in their care. So it could be that they need physical help. Say somebody requires the use of a walker or a cane, and their walker or the cane is not near them and they're unable to get to the bathroom. Or it could be somebody that has dementia or mental function deficiency. So functional incontinence. So it's not related to another urinary problem, it's related to their inability to get to the bathroom or care for them. One thing that we see in those people that are in long-term care facilities is they become what we call institutionalized. And therefore, as a result of needing help, don't get up by yourself. You need somebody to go with you. They have increased cases of incontinence. Overflow incontinence is associated with urine that's lost when the bladder is over-distended and they're unable to empty normally. You'll see it with a spinal cord injury or somebody that has benign prostatic hypertrophy, where they will have dribbling of urine, and that's overflow incontinence. Total incontinence is somebody that has a continuous and unpredictable loss of urine. Could be from surgery, trauma, or a problem with formation of the ureter. And if you have tried bladder training and it doesn't work, so the person with total incontinence is neurologically impaired quite often. So it's important that we use the right products for absorption of urine and collection of urine. It could be a Texas cath in a male. So on page 829, you see the nursing interventions for somebody with stress or urge incontinence and functional urinary incontinence. So starting off, we need to identify what type of incontinence they have, and it may require either the patient themselves or staff collecting data identifying their urinary habits. So they keep a journal of some sort, some kind of collection. So teaching a person how to do Kegel exercises is important. We've covered that a few times in this year so far in the maternity lecture and in 105, but it's also in this chapter as well. It helps strengthen the pelvic floor muscles to prevent incontinence, so proper performing of these is important. So encourage fluid intake. Irritation of the urinary tract can occur when the urine is concentrated. So making sure that the urine is dilute enough. Avoiding of alcohol and caffeine, because that can irritate the urinary tract, and alcohol causes increased urination. Discuss the use of incontinence products. And there are specialists in incontinence. Sometimes in nursing, it's a wound ostomy continence nurse. They can be a source of information for people with certain types of incontinence. For urge incontinence, a person should be encouraged to void every 2 hours and then stretch that time out between voiding. And also distraction. So this is somebody that's urinating on the way to the bathroom. They can't get there fast enough. And so relaxation techniques or distraction techniques, relaxation breathing and counting backwards from 100 by 7s, that can possibly help them get to the bathroom without an incontinence episode. With functional urinary incontinence, we collect the history of incontinence episodes, and they'll be, look at it to determine what kind of incontinence and when the incontinence episodes may occur, so that assistance can be provided in the proper time. Make sure that their clothing is easy to get on and off. Sometimes that's the issue, that they can't operate the belt or unbutton buttons, so we can address their ability to undress themselves by changing their clothing. Make sure that there's no obstacles in the lighting and that there's assistance when needed, and provide initiate a voiding schedule every 2 hours. Oftentimes you'll see voiding bladder schedules that'll be upon awakening, before and after meals, and as needed. So are there needs being met to avoid incontinence episodes? Use proper prompted voiding techniques. So checking the patient regularly, positive reinforcement, prompting the patient to the toilet, praising after toileting, returning the patient to the toilet in a specific time. So this is the key, is making sure we're following the schedule. Urinary retention can be acute or chronic. Acute can be related to anesthesia post-surgery, can be related to medications, to trauma, to structures, and can, as a result of the retention, the bladder can rupture, or we can result in an acute kidney injury. Chronic urinary retention can come from an enlarged prostate. Some medications, strictures, tumors, diabetes can result in chronic urinary retention. So we can assess urine output. So if there's decreased urine output and we're thinking, well, they had a lot in, let's see. So palpation and percussion of the bladder can be done. You can assessing for bladder distension, and a bladder scan can be done, which assesses how much volume is in there. Oftentimes we'll do a residual volume bladder scan after somebody's voided to see how much is in there. Normal should be a small amount after a void. If you have 150 to 200 mLs, that may indicate you'll have an order for a straight cath if it's greater than whatever, if it's greater than 200 mLs. So that's with a bladder scan. Some facilities are using a bladder scan to assist with incontinence. They can be expensive, but sometimes you might have one or two on a floor, and that'll help with incontinence program. Urinary catheters. We in the good old days, urinary catheters were instilled or put in for somebody that was incontinent, and there's an increased incidence, of course, of urinary tract infections. In order to have a indwelling catheter, there needs to be justifiable reasons: a neurogenic bladder, urinary tract obstruction, shock, etc. Wounds, significant wounds, not just a stage 1. So urinary catheters, the data is out there, can contribute to infections, sepsis, discomfort, increased hospital stays. So it is not it's not something that's done so much anymore. Intermittent catheterization is a good way of dressing somebody that has a neurogenic bladder. It reduces the risk of infection. The patient can be taught to self-cath. You see all the commercials these days for getting the right catheter. Choosing the right catheter can be shipped to your house. When somebody's home, they might reuse them, but in the hospital, it's one-time use. It's straight cath, and then it's thrown in the biohazard. But a patient at home might be taught to clean it out and reuse it, being that they're the only one. Suprapubic catheter is inserted into the lower abdomen, into the bladder, so by the above the pubic bone. You can see they have belly bags for the collection of urine, or it could be the same kind of collection device, such as a drainage bag or a leg bag, can be used, and it's for a long term because it's through an incision in the abdomen. The remaining slides are review questions. You can look through them at your leisure, and we'll start the next.